Kia ora, and thank you to everybody for signing up to this webinar. My name's Sam. I'm one of the Fertility Associates doctors. I'm based here in Mount Maunganui. We've opened a clinic here just a little bit over 6 months ago, and I've been with the company for a little bit over a year and a half now, and I was really happy to be able to present a webinar today. I thought I'd just start really basic and just kind of go through some of the basic things that we might see from my perspective, and then look at more specifically what I thought I might like to know if I was to be a patient at some stage. And so I don't have the capability or the capacity to allow sort of interjections and questions as the presentation goes on. But through the Zoom link, there's a Q&A panel, and so at the end, I'm going to go through the questions, and I'll endeavour to answer as many as I can, and as much depth as I can at that stage of the presentation. Okay. So yeah, as mentioned, I just wanted to provide a little bit of background on what infertility means in Aotearoa, with a view to trying to ascertain some of the causes that we see commonly, what initial treatments and advice might be able to be offered at the kind of the community level before getting into more of a specialist context, how you can engage with fertility services, through us at Fertility Associates here, and then basically just some of the treatments that we have, who they might be right for, etc. And then the most technologically involved treatment that we have is IVF with genetic testing, and that comes quite relevant in the context of miscarriages. So I just wanted to spend a little bit about some of the factors that lead to miscarriage, as that's actually becoming an increasingly common presentation that I might see as well. And as mentioned, there'll be plenty of time for questions at the end. At the end, I'll have my contact information as well. I work here at Fertility Associates. I also work as a gynecologist, and I work as an obstetrician and gynecologist at Tauranga Public Hospital as well. So it's alarmingly common in fertility. About a quarter of all couples will find that they have trouble starting a whānau when it's time for them to do so. It's defined as 12 months of unprotected sex without an ongoing pregnancy. The way that that definition is made is interesting. So if you take 100 couples and you follow them for a year, you'll find that by the end of that year, there will be around about 10 of them that haven't been successful with the pregnancy. And that's how the definition was made. It's arbitrary. It's kind of a convenient definition. It's an easy one to remember. Um, but if you look at it in more detail, a lot of people actually should have fallen pregnant a little bit earlier than that. So within the first 3 months, it's not unreasonable for 40% of people to have expected to be pregnant. And then as the months go on, the chance of becoming pregnant or once you're in that month 6, 7, 8, 9, the odds are decreasing at that stage. So traditional advice is to seek referral after 12 months, but I do think it's reasonable to seek referral at an earlier stage if you are kind of getting towards the end of the year, and particularly if there's some issues that you already know about. So if you have no fertility issues, both heteronormative couple, male, female, both normal age, no issues, nothing to speak of medically. The average monthly chance of falling pregnant is about 20%, and so most people in that circumstance, you'd actually expect to be pregnant within about 4 months. But then when you start throwing one or two small factors in the mix, and that might be male age, female smoking, past history of infection, or whatever, even if it's not a very strong factor, that really pulls down the monthly chance. And so I say that to reiterate, if there are those factors that are present, then it is reasonable to seek earlier referral. A lot of the issues that we deal with are really just if we're seeing people a little bit later in the journey, and can feel sometimes like the window has missed some people. So if you know about those factors, I encourage you to be proactive. In terms of causes, it is pretty evenly split across male factor, female factor. It's often a combination of the two, and uh, sometimes you do end up in the situation where science actually doesn't have the ability to explain all the different causes, and that's a bit of a tricky one I find in practice because you don't want anything wrong with you, but sometimes it's easier psychologically to have an enemy that you can direct your attentions towards. And so So I do find that increasingly people are coming forward with unexplained infertility. I would hope that as the years go by and science evolves and technology improves, that the percentage of factors that are relevant for infertility decreases as we get to know a little bit more. But that's about how it is at the moment. About a third of people have unexplained infertility. Common factors for both men and women are cigarette smoking, and so I think everybody knows that cigarettes are bad for your heart and lungs and all sorts of things. But I didn't know before I started looking into it that it can increase the risk of your children and your grandchildren having DNA damage and cancers. I didn't know that it was so relevant towards miscarriage risk from a male perspective, and I didn't know that it was so destructive to the fallopian tubes for the female of the couple as well. And also it can really speed up ovarian aging and egg aging and egg decline and bring on menopause as well. So that's a clear first modifiable risk factor that can affect both men and female. The other thing that can affect both members of a couple are sexually transmitted infections. And if you've had a STI in the past that's made you crook and you've needed to come into hospital and you've had fevers and antibiotics through a drip, then that's quite an obvious and a memorable event. But a lot of people will not have symptoms with STIs, so sometimes it is worth considering a past history of infection as a factor when you are getting into that unexplained criteria. And basically, what happens if you have an infection that is able to get within the reproductive tract for men or women, it can cause scarring, basically, inflammation and scarring. And that inflammation can be destructive to sperm and to ovaries, and it can leave scar tissue behind that can actually block the release of sperm or block fallopian tubes. Sometimes, if there's enough inflammation and aggravation going on there, it can actually cause communication between sperm and blood, and that can cause the production of antibodies against your own sperm. And so sometimes it can cause infertility from those different factors. With men, the basic sperm count's quite straightforward. The workup for men is quite simple. It's generally speaking, it's just a count of how many sperm are around, and so that's a product of volume and concentration. And then within the sperm that are there, there'll be plenty that have two tails or two heads, and so you need a decent percentage that have normal form, and then you want a decent percentage that are able to actually move. It requires specific motility to be able to navigate from the cervix up to the fallopian tube, and then that motility is also how eggs are fertilized as well. So sperm count, where it's pretty straightforward. There's some simple advice that's required so that the sample is able to be analyzed that the lab will be able to provide. But it's a very fickle test. If you look at somebody's sperm count every week for a period of time, it'll come and go and come and go, and so it's generally speaking, it's quite a inconsistent test. And so this graph is just representative of serial sperm tests of one gentleman who most months have a sperm count that's well within the normal range, but maybe a quarter of the time it actually falls down below those reference ranges. And so the way that that happens is the sperm is almost like a canary in the coal mine. And so if you've experienced a significant systemic illness enough to give you a fever, enough to make you feel crook, enough to have a number of days off work, influenza, COVID, whatever, they're the things that you might quite commonly expect to have during the traditional, typical Kiwi winter. That'll mean that your body is not so focused on sperm production, it's more focused on just getting better. And around about 8 weeks later, the sperm count will be at its lowest. And so sometimes when I get a sperm count, it's worth just inquiring if there's been a period of significant illness lately. But most people have been crook within the last couple of months, so I don't bother getting too forensic about trying to figure out what that is. But effectively, it just means, if I have a borderline sperm count, it's always worth repeating because sometimes it can just be uh, not a consistent factor. If there is a problem then and it's present over multiple tests, then that's when you need to start thinking about, is there some chemical reason or hormonal reason why sperm's not being produced? Is there some genetic reason why sperm's not able to be produced consistently forever? Or is there some sort of blockage where the anatomy is a little bit off? And sometimes it's a combination of ultrasound scan and blood tests really to try and get to the bottom of that diagnostic pathway. Just general causes from a male perspective. I think we spend a lot of time talking about female age in the fertility space and de-emphasizing male age. And there's I'm sure there's plenty of patriarchal reasons behind that, and it certainly is de-emphasized, but it remains true that the male age is very relevant as well. And for example, like if you have a female of the couple that you might expect, 50% chance of success with IVF, if her male counterpart is over the age of 40, then that may potentially half that rate. And so it's not, there's no blaming or shaming or trying to pin it between female versus male or anything like that. But it is just good to know, and it is good for men to be proactive with their age as well as women. And we see a lot more people coming forward lately for sperm freezing as well as egg freezing, and I think that's quite a helpful change. So what to do about um, abnormal sperm is pretty straightforward. So um, basically, you just need to ejaculate quite frequently, and if sperm is left in the tubules for too long, then they're effectively exposed to the environment, and with time and heat and stress and diet and whatever, it can just cause the DNA to start to break down. And so there is good evidence behind frequent ejaculation as one of the first causes if the sperm health integrity looks a little bit skew. In terms of the female side of things, the anatomy is more complicated. You need fallopian tubes, you need healthy eggs, you need an egg to be released, you need the egg to be released and collected by the tube. The tube needs to be sufficiently functional to allow the egg to mobilize down the fallopian tube. Then the whole business of fertilization needs to take place. It needs to continue moving towards the womb. And then the womb needs to be sufficiently receptive and welcoming and accepting of an embryo at that stage. And so there's just more factors along the way that could potentially be affected by various conditions. Um, One of the most common things that we might see is people that are not releasing an egg every month consistently. So if a period comes 28 every after 28 days one month and then 27 the next and 30 the following and then back to 28, that's fine. That's well within the range of normal, but it's quite uncommon to have a period that lasts more than, 37, 38, 39 days consistently. It's a little bit uncommon to have a shorter period as well. And certainly if the length of time between periods varies by more than 7 or 8 days, then that's when I start to be concerned that maybe ovulation's not occurring every week. The most common cycle length is probably around that 27 to 28 days. The other thing would be tubal blockage. That would account for a reasonable proportion of fertility delay and is probably the underlying impetus between the creation of IVF. That can happen through infection and smoking, as discussed before, and also endometriosis, which I'll discuss subsequently. Um, if somebody has significant symptoms of endometriosis, then it might be prudent to push for a surgery to go on and have a look and treat endometriosis, as that is a useful way to look to see if the fallopian tubes are working or if they're blocked. But it's quite an invasive thing to do, and so for most people, if there isn't that additional benefit for knowing about those other conditions, then generally some sort of X-ray or ultrasound scan-based test is better. And a hysterosalpingogram is a common X-ray based test. A cynohistogram is an ultrasound scan based test. And they both work on the premise of something filling the womb with a little bit of pressure and then seeing with those images if that same liquid or gas bubbles in the ultrasound setting they spill out of the fallopian tubes. So those are the sort of things that we might recommend if we're worried about a past history of tubal infection. Unfortunately, over the last few years, that's gone from being a funded test in most hospitals to being an unfunded test in most areas, which is a shame, and it's a little bit of a kind of nasty aftertaste of COVID changing the way the healthcare system was prioritized, and so those tests actually do are sort of not financially feasible for some people, and they do end up kind of coming in around about that $1,000 mark. But that is often a decision that we need to have if there's going to be yield for that value. In terms of endometriosis, I feel like I see that all day, every day, and that probably forms the bulk of my work outside of fertility associates, and most people do present with pelvic pain. In my experience, pain that's really predictable, consistent, and specifically building up in the days before your period comes. I've found in my experience that that's been the most consistent symptom that might predict endometriosis as opposed to pain related to the period that's not abnormal. But they're down with there on that list. The other thing that the other reason I'll see endometriosis is with infertility. Um, and so sometimes people can have really bad endometriosis and not a lot of pain or symptoms, and the reverse can definitely be true as well. So endometriosis is a horrible condition. It causes lots of morbidity. It's very, very poorly researched. It's very poorly understood. But the main thing that happens is it causes effectively some sort of scarring or bruising effect to happen month on month where it shouldn't. It happens internally and it happens around the ovaries and around the fallopian tubes. And every time the body recognizes that insult, it sends inflammation, it sends chemicals, it sends things down into that area to try and clean up that bruise or clean up that insult. And those carry chemicals, and the chemicals in and of themselves can be toxic to sperm and toxic to ovaries and toxic to eggs. And then they can leave behind scar tissue as well, which can certainly cause blockages and anatomical distortion as well. Sometimes people experience significant pain with intercourse, and that will decrease the chance of falling pregnant. And it's always very important from people on my side of the consultation to make sure that people will feel they're not forced into having sex and that they're safe in their relationship and that that those sort of areas are being addressed as well, because obviously that's a a basic human right. And then the other thing that I embarrassingly have to admit is that sometimes surgery for endometriosis can be too thorough, and if it's too thorough, particularly if the endometriosis is around the ovaries, that can actually decrease fertility chances. Sometimes it gets into a complicated discussion about what order to do things. Sometimes people are really struggling with endometriosis and they're a little bit snookered in terms of the focus being towards management and down-regulation of endometriosis with hormones and contraceptives, but also wanting to fall pregnant and not being able to use contraception and then needing surgery, but needing to curtail the surgery at a level that helps with fertility but doesn't harm the fertility. And so I don't think that patients should have to advocate for themselves. But if you are in a situation whereby you or a loved one needs surgery for endometriosis, please make sure that your doctor is aware of your fertility desires, prospects, outcomes as well, just so that he or she has that in mind whilst they're considering what treatment options to do. Probably if everything was created perfect with endometriosis, one would, and if severe endometriosis is known, probably the perfect sequencing would be to push forward with something like IVF up to the point of nearly being pregnant, and at that stage freezing everything and then getting a really aggressive, thorough, well-rounded surgery for endometriosis and then continuing with the pregnancy. But sometimes we don't always have those options available to us. Okay. So the other thing we spoke about male age a little bit earlier, and it's been a global trend. I think broadly speaking, it's a good thing. There's massive societal issues with gender pay gap disparities, and I'm not that well versed on sort of societal politics and things like that, but I think broadly it's very difficult to argue against equity. But potentially that may have been part of the reason why the average age of first child has increased over the last few decades. And so my parents' generation, it was quite common to be starting their first child in the early 20s, and these days it's more in the early 30s, and that is what it is. But that has definitely been a trend that has led to an increased proportion of people with fertility. Um, the way it works is mainly due to decreased egg numbers and decreased egg quality. And so the following graph just shows the monthly percentage chance of getting pregnant based off of age. And so it's quite a stark comparison between, say, a 30 or a 40-year-old. It's more than a threefold difference in the monthly chance of falling pregnant. So things that are modifiable that can be controlled, really for everybody. I think this slide's a little maybe a bit more specific to men. It's just trying to achieve and maintain a normal, healthy body weight. Some antioxidants in the diet are good, and that can be an antioxidant type of a diet. Menavit for men can help with that sperm DNA issue that I spoke about. I don't know if I have a really clear science to back up teetotaling, like no alcohol whatsoever, but certainly less is more, and binging will probably affect the health of sperm and subsequent fertility prospects. As mentioned, frequent ejaculation and loose-fitting underwear so the testes are kept cooler than the body temperature. The antioxidant diet is broadly Mediterranean diet. It's pretty easy to Google, but effectively it's trying to avoid processed food, not too much red meat, and having healthy fats. With women, it's the same with regards to smoking weight. Everybody who's thinking of getting pregnant in the next little while should, in my opinion, be taking folic acid, and that sometimes can be in the form of Elavit or a preconception a vitamin package. But you definitely don't want to be folate deficient during the first trimester, and so sometimes it might take a few months to build that up. So if you just start taking it effectively once you start thinking about having a child. Make sure your immunizations are all up to scratch. And if you're on a number of medicines, it's worth just having a quick discussion with your family doctor about if there's any that can be adjusted, modified, particularly if they might interact with your fertility prospects. And it's really complicated. There's lots of medicines that will have vague information on it. And so, if possible, a heads up to your GP about I'd like to come and discuss the medicines and fertility or something like that so that he or she can do a bit of research because nobody can be expected to kind of keep all of this stuff in their mind and the evidence changes all the time. Initial strategies, and so sometimes I see people that are really quite fixated on ovulation and ovulation test kits. Sometimes people don't have much of a basic idea about ovulation at all. And there's many strategies, between the two. And sometimes people think, having sex that more is more. And so there's a little bit of tidying up around just fertility window that can help. And so interestingly, the most likely day of falling pregnant is having sex around about 2 days before ovulation. And so sometimes if you're waiting for the ovulation test kit, you're kind of hamstringing yourself a little bit. So by and large, your chances of falling pregnant whilst awaiting, if you're awaiting that, will probably be reduced. So my general advice for somebody that has a roughly monthly cycle is don't worry about the first week because they're menstruating. Sometime over the next 2 to 2.5 weeks, you'll ovulate. If you're having sex every 2 to 3 days, that will be enough to make sure that each time you're having sex, there'll be good, there's been a chance to replenish the sperm count. Having sex more frequently, the sperm count might not be high enough at the time of at the most fertile window. And then sperm lasts for roughly 5 days and the egg lasts for roughly two. So with that approach over a number of months, eventually that should kind of tilt the odds as much in your favor as possible. And also trying to take some of the stress away from it. So really, really fixating on ovulation and fertile window. It's not very fun. And the more stressed you are, the less likely you are to sort of ovulate and produce good quality sperm. So just trying to really pare it back and keep it simple is, in my opinion, the right thing to do. All of this is summed up very nicely on our website. I think our website's actually a really useful resource. I don't think it's very, it's, I don't feel like it's very propagandary. I don't feel like I feel like it's quite general, non-specific fertility advice. And I do think it is a good, useful stepping off point. If nothing else, it's just hard to circumnavigate the internet sometimes with looking for medical advice. And so it's a good initial foray. Within that website, it's also a way that you can look at referring yourself to see us. And so there's a few different ways that you can see us, and we would like to see everybody and anybody. I don't have any care in the world at all about how a couple or a single person might define him, her, or their self. And we think that the ability to start a family is something that everybody deserves a chance at. And so on the website, one can self-refer for a doctor's appointment or a free nurse consultation. The free nurse consultation is a really useful starting point. Sometimes the reason to see us is because you really want a baby and you want it now and you just want to get onto the best treatment straight away. Sometimes it's literally just an information session, and a lot of people will finish a consultation and just feel a bit better about where they're at, and it takes some pressure away. Sometimes people might leave a consultation and they're like, "We need to crack on," and sort of it's just good to know. It's your information to do what you want with, but it's just good to know. We will gladly accept anybody that is willing to donate eggs or sperm, and we'll gladly accept people that are willing to be a pregnancy surrogate for another couple. Um, Happy to see people with recurrent miscarriages, and then very, very quickly we can see people for fertility preservation. And so this is the type of situation whereby somebody in fertile age might be diagnosed with a cancer that could mean that they need radiation or surgery to the ovaries, testes, cervix, uterus, something like that. And in that circumstance, we can normally see people within 2 or 3 days, and try and get some fertility treatment underway immediately, to the point where we're not delaying their cancer treatment, but we're keeping their options open for fertility going forward. Um, in terms of the first appointments, they can be free if you meet certain criteria, but part of that criteria is that you have to be referred from a doctor, so your GP or another specialist, whereas people can self-refer, but that comes under the private setting. Furthermore, under the public, the funded setting, need to meet certain criteria, and so there's restrictions on who can receive fertility treatment that's funded by the government, based off of, I guess, like a balance of how much funds are available versus how many need them, versus what factors are more or less likely to provide success. And so there are restrictions with regards to female body weight, smoking and vaping, age, and then need to be eligible to receive healthcare in New Zealand. Now, when we see people for the first time, you shouldn't really need to worry about having any, like, proactively sorted anything out yourselves. It's all coordinated by a brilliant admin team, our nursing liaison team, our coordinators. Honestly, run a really slick professional operation with regards to that sort of stuff. And so, when I'm seeing a patient for the first time, I should, in almost all instances, have all the information that's required to figure out the diagnosis and the treatment plan. And so, it's generally speaking, it's blood tests and sperm tests. Um, an ultrasound scan sometimes has already been done. Sometimes it's not required, but it's often done at the appointment. And during that appointment, it's also trying to really figure out, explain what's involved in applications for funding and timelines and so on and so forth. Funding is almost always takes the form of IVF, and then it's a case of just trying to see if there's sufficient points to receive eligibility for funding. Generally speaking, one can receive funding if they have unexplained infertility for a period of 5 years, or sooner if there's a diagnosis. So, for example, if there's severe endometriosis, then you immediately make the funding points. If the tubes are blocked, immediately make the funding points. If there's like a mild reduction in sperm, then that would just reduce the amount of time, but not down to zero. And so, kind of combination of time and factors is generally speaking the way that the funding is done. So as mentioned, sometimes it's just as simple as advice. If people have irregular cycles where they're not ovulating, then the simplest treatment available to those couples is medicines to help with ovulation. Sometimes it's a case of providing advice and treatment around artificial insemination. There's IVF and there's other things in addition to IVF. Sometimes people like to come forward to freeze eggs, sperm, or embryos, and then I'll talk about third-party reproduction as well. Okay, so when seeing a couple for the first time, I like to know how long they've been trying. I like to try and get the diagnosis sorted to the best of our ability. Then it really comes down to prospects going forward and how much time do we have, and part of the marker of how much time do we have is desired family size, and so I intuit that most helpfully using AMH, and so AMH is a test that effectively counts how many eggs are left. Eventually, everyone's born with a set number of eggs, and they just steadily go until you go through menopause. It doesn't often come with any symptoms, and so most people don't know if they have a high egg reserve and therefore a bit more time, or a low egg reserve and therefore less time until the AMH is tested. And so sometimes it might be in a situation where the AMH currently is looking pretty good, but maybe for baby number 2 or 3, it might have ducked down to the next sort of level of threshold. And so I'll interpret the AMH sort of longitudinally to try and see, where we are now, where might we be for subsequent pregnancies. And it's also crucial to how we dose the medicines that we prescribe here as well. The other thing that I'll look at, this is not very specific, this is population data, is just looking at age and the different treatment options. And so in the blue line is the chance of falling pregnant per month naturally, based on age. And so you'll see the age of 31, it's 21%, and the age of 41, it's 4%. And then the green line next to it is insemination. And so for some reason, we'll see in some age groups, insemination is lower than natural conception. And then as one ages, then it starts to get up a little bit. But then in the red bar is the chance of falling pregnant per month with IVF. So in terms of ovulation induction, this is just relevant to people that are not ovulating. And so if you are ovulating, you can't super ovulate. In fact, you could run the risk of having triplets or quadruplets if you were to overcook things. And that comes with all sorts of risks as well. And so there's two basic medicines that we use. For most people, we would use letrozole first. Letrozole is just found to have a slightly higher live birth rate and a slightly lower twin pregnancy rate. It's just not possible for some people. I'll go back. The way ovulation induction works is a medicine is given on days 3, 4, 5, 6, and 7 of the menstrual period, and then there's a degree of monitoring. The monitoring is in the form of blood tests and scans, and you could theoretically be on the perfect dose straight away, on too low a dose, and that wasn't enough to make one ovulate, or too high a dose and ovulating from too many follicles, in which case that would carry a too high risk of twins or triplets or things like that. So sometimes people need a month or 3 to really get that dose right. Insemination is the same general concept whereby that medication is given. There's really tight monitoring of the hormones via a bunch of blood tests and a scan or two. Often ovulation is then triggered so that the timing is perfect. And then a sperm sample is provided by the male of the partner, or a sperm donor perhaps. And then that's placed through the cervix into the womb at just the perfect time. And this is a non-specific, so I've this website that I like to use, and in this particular circumstance, I think I've made this patient up, and I've guessed that she's 38 with an AMH of 25, and they've been trying for about a year, would be what this kind of picture looks like. And in that circumstance, I've got the chance of falling pregnant, of having a baby naturally over the course of a year being close to 20%, versus insemination after 1 month being close to 10%, after 2 months being close to 20%. And so I'll play with this website to try and get some estimates of success as well. And then lastly is IVF, and it does feel like all roads lead to IVF to some extent, but it's not necessary for some people. And the real benefit is it just frankly is the quickest time to have a baby. Even if it's unexplained infertility, the evidence would still generally point to IVF. I think it is relevant to family size, as I spoke about that AMH graph before. So it's a hedge against aging. So IVF locks everything in at your current egg and sperm age and quality. And so it doesn't matter if you do well from a round of IVF and you have eggs or you have embryos frozen, then it doesn't matter if the AMH drops with time. That means that all that mana is done early on in the piece. And so it is, if a larger family size is a motivating factor for a couple, then it behooves us to go to IVF sooner rather than later. It allows access to freezing, allows access to genetic stimulation, and it's honestly is very low risk. Some people feel a bit crummy on the hormonal medicines. Sometimes that can tick over to overstimulating the ovaries. And then occasionally in the procedural side of it, there is a risk of infection, there is a risk of bleeding as well. It's just expensive. So the Ministry of Health will fund up to 2 cycles of IVF publicly. but there's a significant wait time to access that actual treatment. So sometimes people do feel that sense of urgency and need to consider paying for it privately. So IVF is effectively give you a medicine that stimulates your ovaries. In a normal month, the natural version of that medicine will stimulate maybe one follicle, maybe two. The medicine that we get will hopefully stimulate as many follicles and therefore eggs as possible. So that's an injectable medicine that is normally needed for about 1.5 to 2 weeks. The um, response to that medicine is monitored with scans and blood tests. Most people need to come in for about two, sometimes three scans and blood tests to track how it's going. Then ovulation is triggered, and then a day and a half later, eggs are collected. And that's done with an internal scan and a needle, and then that needle drains the fluid from the ovaries. Um, it is slightly uncomfortable. It shouldn't be sore. And the way that we achieve that is with some local anesthetic around the needle, but more specifically with some pain relief and some sedation. Then on that day, those eggs that are collected, you'll know the exact number immediately, and then they need to be fertilized. And so the fertilization, if there's a decent sperm count, will be in the form of IVF, where sperm's washed around the egg and allowed one sperm to get in and fertilize the egg. If the sperm count is lower, then that couple will need ICSI. And so ICSI is where one good quality sperm that has one head, one tail, and is moving in the right direction is selected and then placed directly into the egg to guarantee that fertilization. The following day, we'll know how many of those were fertilized, and then generally speaking, on day 5, we'll know how many of those have made it to the embryo stage. And the embryo stage is when the pregnancy is ready to start. It's a stable, um, relatively mature unit of DNA, and so that's really what we're hoping to get is to get as many healthy, good quality embryos as possible. And so for most people, then that the best embryo will then get transferred into the womb. The rest will be frozen. Okay. There's no difference in pregnancy rate if it's completed as a fresh or if it's a frozen embryo that then gets thawed and replaced in another month. Sometimes it's safer to wait a month. Sometimes it's indicated for various other reasons as well. And then there's a degree of surveillance and additional medicine to the first trimester of pregnancy to decrease the chance of pregnancy loss. So this same couple that I was playing with on this website before, 38-year-old female, AMH at 25, insemination success rate of 10% with one round of IVF, it's closer to 40%. And then the hope is that there'll also be extra embryos that can be used for embryo transfer from that same round as well. In terms of freezing, people can self-prefer. As I said, we're having more people come ahead for sperm freezing. Most of the work, I suppose, would really be directly between the male and the scientists that we work with. But I must say, we do see a lot more people coming ahead for egg freezing, proactively trying to maintain their autonomy over their fertility going forward. At the moment, at least in Tauranga where I work, the wait time for donor sperm is relatively short. And so sometimes it is worth considering freezing eggs versus finding a sperm donor and freezing embryos. Sometimes if there's a couple that don't want a pregnancy right now, they might have that discussion between freezing eggs versus freezing embryos. The key difference is that you need more eggs than embryos because the egg is not as stable as an embryo. But the egg is a woman's sole custody and embryo is joint custody. So if that relationship were to break down, then those embryos wouldn't be able to be used. And so sometimes that's a bit confronting and kind of accelerates those portions of the relationship ahead of time, but it's better to enter that with your eyes wide open. So when I have a patient that's looking for egg freezing, as always want to know the AMH. And then with the AMH, I can guess how many eggs that she might be able to collect. And then with the age, I can guess how high quality those eggs are. And so those eggs need to go through a little bit more than an embryo because there's a second round of thawing, fertilizing, and thawing and transferring that's in addition to what you would do with the standard round of IVF. And as such, you do need more eggs. And the amount of eggs required for a 50% chance of having a child is indicated here, and it's dependent on age as well. So some people, if they have a really good AMH and they're under, they're 35 or what have you, So they might be okay with 1 round of egg freezing. If they have a lower AMH or they're older, they might need 2 or 3 rounds of egg freezing. And so that's part of the initial consult as well. Within IVF, it also opens up the world of genetics as well. And so sometimes people will have DNA that's within them is perfectly balanced, but when it needs to be shared with somebody else, the balance is off, and that can lead to recurrent miscarriages. Sometimes people will have a genetic disorder that they know, and it's recessive. Often that is, if they've for their second child, they might have found out about this genetic disorder by giving birth to a child that's affected by a rare genetic disorder. And in those circumstances, embryos can be biopsied and tested most often for those conditions to make sure that uh, the DNA of the embryo is known before proceeding with the pregnancy. And then the last thing that I've got down is what we call PGTA or aneuploidy. So aneuploidy is not a necessarily like a it's it's not necessarily indicated medically to treat a condition. It's more to try and ensure that you know that the DNA is balanced before starting a pregnancy, more from a miscarriage risk. And so the pre-implantation genetics is available for the usual funding criteria. And so we'll see that sort of relatively often as well. In terms of miscarriages, so sometimes people will have a structural cause for miscarriage whereby there's an area of the womb that's different than adjacent areas, and that can be a persistent cause for miscarriage that requires a surgery. Sometimes people have a issue with the biochemistry in their body that makes a pregnancy more likely to be rejected or a placenta less likely to thrive, and that can be tested for with blood tests. Sometimes it's cigarettes and alcohol and obesity and the same old things that are bad for everything. But oftentimes it's genetic imbalance, and that's where aneuploidy comes in. Aneuploidy refers to when the DNA is imbalanced, it's either excess or incomplete. And that really pulls up the pregnancy loss rate as age increases. So basically what happens when an embryo is being developed is 2 bits of DNA need to come together, separate, come together, separate, come together, and it just needs to be done perfectly millions of times. And it's no wonder that yeah, I fathom how anyone's even alive when you think about the complexity of it. But effectively, what happens is as the eggs are aging and as the sperm is aging, the scaffolding and the structure behind this process just gets a little bit old and damaged. And it just means that it might get pulled off here, and then eventually, after a few more replications, the balance is just off. And that will cause a miscarriage. If it lines up very, very specifically, then sometimes we have names for that, and that might be what people might know as Down syndrome. That's one version of that. But most of them are never diagnosed or never known. They simply just are recognized as a pregnancy loss, and that is the most common reason for miscarriage. It's one of the main reasons why birth rate really declines with age is because the miscarriage rate really increases, and it increases proportionally to the aneuploidy rate. It's the same for men. Okay, so as the DNA starts to get skew-off, that will also cause that DNA imbalance, and that can certainly increase the risk of miscarriage and recurrent miscarriage in this circumstance. And it's a combination of the two as well, right? So if there's some DNA damage but a good quality egg, then the egg has the machinery within it to actually go on and repair that DNA damage, but only up to a certain point. And so when you get a combination of maternal and male age, that's the most, likely situation whereby miscarriage will increase. And so my way of interpreting this graph is generally speaking, if the combined age is about 70 or more, then we're starting to look at a risk of miscarriage. And certainly if it's 75 or 80 or more, then that's when it's starting to look higher and higher. And so for patients that either have a history of recurrent miscarriage or they have that combined age or other lifestyle factors that might increase it, so then that's when I'll often introduce the concept of IVF with this embryo biopsy. Sometimes that can be done as an add-on to a conventional round of IVF. Sometimes we'll do sort of serial rounds of IVF with batches of biopsy and batches of results to kind of make just to streamline the process to keep the costs down a little bit and people can and that's referred to as Family Builder or Family Builder Plus, and there's information about that on the website as well. But often I'll start to talk about this if I'm worried about either they're worried about miscarriage or if I'm worried about miscarriage, as frankly the best technology available to give ourselves the best chance of a live birth. Okay. And then the last line of work that we do that's actually really rewarding. I get the impression that eventually it gets quite frustrating for the patients because it involves a whole nother layer or a couple more layers of communication and further delays. But effectively, it's people that need someone else to help them get pregnant, and that can be same-sex relationship, or it can be single people, and it can be people that have lost the ability to carry a pregnancy, for example. And we have a whole team that helps coordinate this, and we try so hard to make it as slick and as smooth and the communication as tight as possible. But often by the time people are actually coming forward for the treatment, they do feel a little bit beaten up. Like it is a lot. It's a long journey. Dare I say it, a lot of people in this camp have maybe been had some barriers put in front of them throughout life anyway, and it's really, really, really rewarding when we can help people using our third party reproductive team start a family. It's one of the things I like the most about the job, if we can kind of get trickier things over the line. And so the most common situations would be same-sex female relationship, need a sperm donor, same-sex male relationship, need an egg donor and a surrogate, things like that, and that's the sort of stuff that the third-party reproductive team will do. So that's a really, really broad and shallow overview of what's available through Fertility Associates, and I'm very proud to work for FA. I absolutely freaking love it. Like it's been such a nice addition to my work week. I do about a third of my week is here, a third's in the hospital, and a third's just as gynecology, and I really love the way they all the different aspects talk to each other, and I'm very happy to be reached on any of the first two are resources to look for fertility stuff, and the last three are my contact details. So I'm very happy to be contacted if any questions come up that you don't feel comfortable asking in this forum. But now I'll take some questions. So forgive me just while I download I just have a look at the Q&A tab. Okay, so the first one is what investigations are done to find out the cause of recurrent miscarriage? Yeah, brilliant question. So one would be looking at the male and the woman's carrier type. So that's the map of DNA, and that's to look to see if there is that imbalance that if that's fine in one person and not in another. The other would be antiphospholipid syndrome antibody screen or thyroid testing. So that's kind of that chemical issues. Sometimes there might be an anatomical issue with the womb, and that might be some combination of an ultrasound scan or maybe a hysteroscopy. And very occasionally we'll find that there's just a chronic inflammation or infection at the level of the womb, and that might require a biopsy from inside the womb. And that can either be done at the time of a hysteroscopy or with the office biopsy, which is called a papal. Um, the next one is smoking cessation a few months ago. Kia kaha, that's excellent. Yes, so even quitting smoking for a couple of days will improve your health. It'll improve your cardiovascular health. It will decrease the amount of toxins. If you've been a heavy smoker for many years, as a female, that could have caused more eggs to be used up in those years. So it could potentially have permanent effects to the AMH and the egg reserve. But even a few months ago, that in terms of that toxicity and the health and the DNA, there would definitely be beneficial impacts of that. I think if you quit smoking for even 3 months, then that's probably enough to then start trying for a pregnancy if you're hoping to, optimize your health before moving forward. And in terms of funding, if someone's quit smoking for 3 months or more, then that's when they're eligible for funding. If they're currently smoking or they quit it less than 3 months ago, then they need to wait a little bit longer. Um, okay. So a patient is irregular menstrual cycles, confirmed ovulation, no other tests, trying for 6 months with 5 cycles and one chemical pregnancy. When would you recommend coming into fertility? Look, I think, I mean, honestly, I really hope that I find it hard to, um, what's the right word, sensitively input that information about like an early pregnancy loss because on one hand, it's bittersweet because it at least showed that like one tube had to work, one egg had to work, and one sperm had to work, but it still no one feels good that they've had a pregnancy loss. So on one hand, I'm somewhat buoyed by that, but honestly, I can understand how you might be dismayed. With regards to trying for 6 months, you would be better informed if you did have an assessment, and particularly with regards to sperm count and AMH. I think it's no harm in sort of seeking referral earlier. Certainly, if there's some actual sort of more significant diagnostic issues, you definitely want to know about those sooner rather than later. And then, frankly, just everything just takes time. So there's delays for appointments, there's delays for treatment, there's delays for tests, there's delays for everything. And so sometimes it's just worth just being on the front foot, frankly. How long after stopping the pill should I wait before trying to conceive? How long will it take to become fertile again? The answer should be hopefully a very short amount of time. Most people in practice, it's around about 1 or 2 months before they start ovulating again. It might be a little bit longer if you've been on the pill for a long amount of time, but it actually spares your egg reserve, and it actually means that sometimes it might mean that you actually have a longer fertility life if you've been on the pill at earlier stages in your life. So I don't think that there'll be any long-term detrimental effects to to having the contraceptive pill on coming years, basically. The next one is I want to start treatment with fertility associates. What steps should I take? I'd refer you to our website. So, I just put in Google FA New Zealand or whatever, and then it'll come up with fertilityassociates.co.nz. And in the top right corner, you could either go for a free initial nurse consultation or you could self-refer for a doctor's appointment. And then that will generate all of the information and testing and questionnaires and stuff that you need to do for a private first appointment, which is a little bit pingy, like it's a couple $100. If the alternative, certainly if you've been trying for a reasonable amount of time, would be to just seek a consultation with your GP. And, most people there'll be that part charge for their GP, but then getting into the fertility clinic that way would open up a public first appointment. If the first appointment is if we've met you through a private channel, but you qualify for public treatment, then subsequent appointments and subsequent treatments and stuff like that can then be funded. The next question is largely the same. How can I book an appointment? Okay, so this is quite a specific question that I need to model. So this is about a patient who's 42, with a very good AMH of 26. What is the chances of being pregnant naturally, and what are the chances being pregnant with IVF? I apologize, but I probably need a little bit more nuance to answer that. So let me just quickly, sorry, I'm just going to see if I can get back a screen. Okay, so on that screen there is the second link, fertility-doctor-app dot blah blah blah. That is the website where you can plug in your age and plug in your AMH and sort of play around with a little bit to look at your natural chances of chances of natural conception versus IVF versus insemination. But at risk of shameless self-promotion, I do think that is needs to be answered within the confines of a more dedicated fertility consultation. I'm very pleased with your AMH though. That is top of the class. Okay. What's defined as severe endometriosis? If you have endo, how many years do you have to be trying to qualify for IVF? So you should meet criteria essentially straight away. You get the maximum diagnostic points if you have stage 4 endometriosis. So the different staging systems of endo is a bit controversial and what have you, but stage 4 is effectively if you've got really significant endometriosis. Now, it has to be diagnosed with a keyhole surgery. So I can have patients that I know without a shadow of doubt, based off of symptoms and examination and MRI scans and all this, that they have endo. But unfortunately, it needs to be confirmed at the time of a keyhole surgery before you can put that over. And so you would qualify for fertility assistance immediately once that diagnosis has been confirmed. If you also meet criteria for funding, and so that's smoking, age, BMI, And there's some other social criteria as well. Like, for example, you can't have two children. Two children would mean that you wouldn't qualify. Okay. Um, so the next one is I'm in a same-sex relationship. Am I still eligible for fertility funding? The answer is yes, but it's unfortunately it is harder. If you're in a same-sex relationship and there's a known biological reason for infertility, then that is treated as for anything else. Otherwise, there's sort of like a what's the right word? There's a conversion factor for let's say a same-sex female relationship, a lesbian relationship. There's the in order to have the equivalent of the points that you generate from 5 years of unexplained infertility in a heteronormative relationship, it's a certain number of unsuccessful insemination cycles. And so oftentimes people will feel like they really, really need to prove their case in order to receive that funded in order to receive that funded IVF treatment. And so there's definitely equity gaps in terms of the cost to couples and the treatment received with regards to their gender and sexual orientation. And I strongly hope that no one feels that there's an empathy gap. But it is true that it is a lot harder. It is a lot harder. But the shorter window version of that is that it is possible to receive funded treatment. Um, Good question. Is the cause of miscarriage linked to the gestation of miscarriage, e.g., recurrent miscarriage at 10 weeks? I don't know. Um, if there's multiple second trimester losses, then that kind of opens up a little specific diagnostic nook. Um, Sometimes if the kind of story of the miscarriage is that there was a period of time where there's a little bit of bleeding, a little bit of bleeding, a little bit of bleeding, and then an eventual miscarriage, I might, maybe it's not the most scientific interpretation of that, but I might start to think that maybe there's just not quite enough progesterone present. And I can't prove that and I can't test that, but I can infer from other ways that progesterone in pregnancy has been tested that sometimes increased progesterone in the first trimester, but until the placenta's got big enough to take over, can sometimes salvage a miscarriage that was heading that way. But otherwise, not really, hey. I couldn't necessarily tell you. I'd still want to do the same test. I suppose I'll put it that way. Um, when would you expect periods to return to normal after a miscarriage, after an ERPOC, normal cycles prior to miscarriage? So an ERPOC is the medical procedure to help complete a miscarriage. I would normally expect around about 6 to 8 weeks. Sometimes people will experience pregnancy loss, particularly if the more involved that is, will experience that with greater deals of stress. Sometimes it can genuinely be can flick over to the realms of post-traumatic stress disorder. I'm making large assumptions on a test on a message with no context, but if you are feeling strong feelings of stress and distress, your body will not prioritize fertility. It'll focus on that fight and flight response. And in those circumstances, it can take longer for ovulation to kick back in. And that's true if you have a loss in your family or a massive life event that remains true. And I should actually just say that we do have access to really, really brilliant grief counseling, fertility counseling, implications counseling as it relates to third party reproduction through FA. Sometimes, even in the best hands, the stats are that more people will not be pregnant than pregnant on any given month, regardless, And so we do experience a lot of people that are experiencing a lot of loss, and we have really, really good access and facilities to help with that. And the counselor that I personally work with where I work in Tauranga is Karen August, and I couldn't speak more highly of her. So again, I may be grossly overreading into your question, but I just wanted to make that plug as well. What is the success rate for ovulation induction medication cycles? It should be your natural conception rate. Okay, so if I look at, if I'm thinking back to my graph of a 31-year-old, I think it has a 21% chance of natural conception. If all things else are created equal and the only thing that's lacking is ovulation, then it'll get you up to that natural conception. Okay. And so normally most people we think it's worth trying ovulation induction for 4 to 6 months. And that would be, and if a lack of success after 4 to 6 months would indicate that it's not just ovulation induction that's required. But most people would expect to be pregnant within that time frame if it's just a case of timing intercourse and ovulating. Uh, If a woman has a regular period and minimal period pain but hasn't become pregnant in over 12 months, what is the most common diagnosis you see? I think that could still be kind of anything. That could be a sperm factor, that could be a past history of tubal factor, or it could be unexplained. It's definitely worth a pretty broad workup for that one. We definitely focus a lot more, and maybe it's because I'm a gynecologist by trade, but um, yeah, I definitely feel like we focus a lot more on the female in the consultation, and that's something I need to work on, I suppose. But yeah, who knows? There could be anything. There could be anything there, or you could have just it could be normal, and you just need one more month. But at 12 months, I definitely think it's worth starting to have a little bit of a look under the hood. And there might be something really obvious and really easy to fix, or it might be unexplained. I'm sorry, I don't know at this stage, but definitely worth having a look. Um, if sperm quality is bad and a single healthy sperm cannot be found, excuse me, can an embryo still be made, or is this too high risk of issues? Okay, that's a really good question. I think that an embryo can still be made. Sometimes we need to fight extremely hard to find one sperm. There's people that have had, say, like a vasectomy, permanent male sterilization, that need to go on and have sperm found. Sometimes there's people. I have a patient actually who unfortunately had a brain tumor just around about the age of puberty. And so not quite sure if he was just about to or hadn't or whatnot, but either way, he had a brain tumor that meant that he never went through puberty naturally. And now we're making sperm for him with some very complicated medical background. And then within our group, we have a few people that are really super specialized. And so sometimes people need some quite specific and highly skilled testicular surgery to find sperm with Dr. McChesney in Auckland. And so I think that if there's a will, there's a way, really. And so I think there are certainly procedures to look there and try and find some sperm. And then, frankly, you only need a couple sperm. You would need ICSI, and it would open up more sort of technology that would be made available, but it would also definitely open up those diagnostic points for treatment. And if part of your treatment requires that in more detailed sperm sort of procedures, then that's covered under the funding model as well. If the sperm quality is that kind of DNA stuff and the DNA is broken down, then that can be improved with regular ejaculation and healthy lifestyle and antioxidants and is worth repeating. But I certainly don't think that that's impossible. Some people do need sperm donors. And so if, legitimately there's just no sperm available for whatever reason, then sometimes people do need a sperm donor. And we have a few couples that, a loving relationship. They need a sperm donor. They go on, they have kids, and they love them and care for them as if nothing had ever happened. And we'd be the right people to help facilitate that as well. And then I think this might be the last one here. So, okay. So I've got a patient who's been trying for 20 months. Can I actually I'm just going to break off and let me just touch on that. So, I won't share your name, PM, but so I do this wrong every single consultation. I start every consultation the same way, and it's dumb, and I'll probably do it for the rest of my life. But I always say, "How long have you been trying for?" Um, and how long have you been trying for is such an open-ended question, and it could mean any number of things. What I'm really asking is, how long have you been a couple and not used any contraception? And contraception is not the pull-out method. It's not timing around cycles. It's not anything like that. Contraception is condoms or the pill or the Mirena or whatever. Okay, so when trying to conceive, sometimes people are like, yeah, we've been together for 5 years, but we've only been trying for a baby for a year, as in like wanting a baby. And so you always take the larger of those two numbers. we try and make it really easy to get on funding, and we round up. Okay, so maybe on reflection, trying is actually longer than 19 or 20 months, but if not, then, okay, there we go. Okay, so let's just say it's 20 months. Have had one miscarriage and recently diagnosed with stage 3 endometriosis, have a normal BMI, no smoking, etc. What do I need to do to be eligible for IVF? Um, I should have a. Okay, let's go through this together. Okay, so okay, so effectively, what you need from the first half of the form that's on the right side of the page is 6 points. Okay, so stage 3 endometriosis gets you 3 points. Okay. So the other ways that you could get 3 points is having a mild sperm reduction, having a mild lack of ovulation, having some issue with the fallopian tubes, or having tried for 4 years. Okay. And so if and the sort of middle and second half of that form, it all just kind of follows on from that. So I suppose the simplest answer for that would be after 4 years of trying with stage 3, if stage 3 endometriosis remains the only issue. Sometimes it is worth checking the tubes if that wasn't done at the time of the laparoscopy. And certainly part of the consultation is looking to see if there's any sperm issues or ovulatory issues as well. And then occasionally you can end up accumulating points from sort of various factors. Okay. And so if basically it'd be like what we'd say is, this is your scoring now. This is the time whereby you would have been trying for 4 months that we can look at applying for funding. And then you sort of look at how long what that means. What does say, maybe you need to wait from until November 2026 or something. Okay, what does that mean? Well, what's the wait times? What's my AMH doing? How long? How many kids do I want? Is it within my means to do that? If it is it not? So that's sort of way that I'd interpret that. Okay. Well, look, those are really intelligent questions, and it honestly really reflects what we're doing on a day-to-day basis. I see a lot of people with very, very similar questions. I feel like I'm seeing a lot of people struggling at the moment. Like I do feel like the kind of collective morale's getting a little bit low, and I really similarly, every morning we'll get a beautiful picture of a baby that was conceived with a little bit of help from us, and that really kind of keeps the sales afloat as well. So, very, very thankful for everybody's attendance today. Obviously, part of today is to, like loosely promote Fertility Associates, and as I said a few times, I love working for FA. I love being able to help people where possible and sort of sharing that journey. And so, very hopeful that you don't need any help from me or my colleagues in the future, but very, very welcome to self-refer or seek referral in any way if you'd like to discuss things in more detail. Thank you for your time.